So hello friends, welcome back to my channel. It is now 101. Now we'll talk about the investigations and the treatment for the acute pericarditis. Okay. So in the previous video I have already explained that what type of the differentiations you will get in terms of the myocardial infarctions and the acute pericarditis, because in the both cases we got the ST segment elevations, right? Now try to understand over here. As I said, in these cases the ST segment elevations will get, and the concave part that will face upward, right? In this case, you see the concave part that is facing upward, and in this case, we will get the concave part that is facing downwards, right? And along with that, okay, here we will get the ST segment elevations, or the concave part that will face upward. In these cases, we will get also the ST segment elevation is the acute myocardial infarctions, and is the acute pericarditis, okay? We will get also the ST segment elevations, but in these cases the concave shape of the ST segment, this concave portions that will face downward, okay? And along with that, in these cases we will also get the pier segment, we get the pier segmental depression. So why you are not getting the pier segment depressions in terms of the acute myocardial infarctions? Try to understand from this diagram. See, whenever we talk about the pericardial effusion, acute pericarditis, at the time we said that we will get the diffuse pericardial inflammations. That means whenever I am trying to understand from here, whenever diffuse pericardial inflammations over here, now see diffuse pericardial inflammation. These portions from here, as we know that the pericardium that will also cover the atrium, right? So from the pericardium, the different kinds of the inflammatory chemical mediators, they can reach from the pericardium to the atrium also. And whenever they will go from the pericardium to the atrium, whenever they will go within the atrium, they will cause the what? Pier segment depressions will get over here. During the atrial, these portions will get from here to here. And these are the diffuse inflammations we are getting in terms of the pericarditis. But try to understand, here I just did mention, if we get the localized myocardial infarctions over here, in the left ventricle basically we see, rarely within the right ventricle. So here there is no chances for the chemical mediators to go where? Within the atrium. So as a result we will not see the pier segment depressions within the acute myocardial infarction. Okay. Now the next thing that I have to know, as we know that the inflammations that is going to within the whole pericardium, and if you see the within the whole pericardium the inflammation that long lasting, as a result we will see the ST segment durations. If we see the ST elevations, the duration of the ST elevations that will long lasting. Okay, duration of ST segment elevations that will long lasting, because it is covering the whole part. Okay, the whole myocardium will get the chances for the development of the myocarditis. But in these cases, as it's localized, so in these cases we'll get the durations of the ST segment elevations that will be less with comparison with the what? Acute pericarditis. So here we'll get the duration of ST segment elevation will less, not like this. And in this case, see this T wave that is going, try to understand, that is going upwards. Now this T wave that will take time to come to the normal positions. For example, whenever this whole ST segment that will come within the normal positions, after that the T wave that will come back to the normal positions. But here the T wave that will come down simultaneously. Whenever the ST segment, see this whole segment that will come to the normal positions instantly. Along with that, will get the T wave that will also come back to the normal position. It will be inverted. But in these cases, the T wave that will take too much time with respect to the. Okay. Now, as I said, we just got how much? We got the four major, or you can say the principal diagnostic features in terms of the acute pericarditis. I just explained in terms of in details about the chest pain. Then I did talk about the pericardial rub. Then I did mention about the ECG changes. Now we'll talk about the pericardial effusion. Now, how can you just define the pericardial effusion? So see, whenever I am saying the term pericardial effusion, pericardial effusions. From the term pleural effusion, it's quite easy to understand. There will be accumulation of, right? There will be the accumulation of fluid. Now let's draw once more. Okay, it's not coming properly, guys. Okay, anyway. Now see, whenever I just said about this thing, that for example is the pericardial layer. Now see, how can I define the pericardial effusions? Whenever you're getting the inflammation within the pericardium, definitely you can see in terms of the different kinds of the exudatory, fluid you will get over here. So whenever we get the accumulations of the fluid in these regions, so normally how much fluid is seen in terms of the within the pericardial layers or within the pericardial sac, near about 15 to 50 ml of the fluid that is present within the pericardial cavity of the pericardial sac, and that will reduces the pericardial rub. That means in terms of, we can say that will reduces the pericardial frictions. Now whenever we will see the ventricular contractions, atrial contraction, at the time this pericardium, whenever these two layers they will glide on each other, at that time we will see this fluid that will inhibit the what pericardial rub. We can say that will reduce the what pericardial frictions in between these two. Now what type of the other things we will get over here, that is the most thing. So as we know, in terms of the pericardial effusions, we will see the accumulations of the fluid here will be more. So the fluid, whenever we get the inflammations from the different portions, we will get the fluid that will reach over here. And whenever we get the fluid that will reach, the fluid overload will get within the pericardium. Now see, whenever the fluid that is getting accumulated within the pleural, within the pericardial cavity, see, whenever we get more amount of the fluid within the pericardial cavity, at that time this fluid separate these two layers of the pericardium. So whenever the fluid accumulations of the fluid we will see within the pericardium, that will be increased. At that time we will see the separations of these two layers in terms of the visceral layer and the parietal layer of the pericardium. So whenever we are seeing that the two layers they are getting separated for the accumulations of the fluid, so there is a whatever the clinical changes we will see, there will be the absence of the what pericardial rub, because at that time we will not get, see, these two layers will be not able to touch each other. As a result, we will see the absence of the pericardial rub for the accumulation of the fluid. So the first thing you can write it over here, that the pericardial rub that will be absent over here. Okay. Now what about the other things we'll get over here? See, whenever the accumulations of the fluid within the pericardial cavity, at that time if we just do the palpations over here within the apex bit, so in these cases we will not be able to hear the we will not be able to do the palpations within the apex. So here we'll get no palpable apex bit. No palpable apex bit. We cannot just feel the palpable apex bit over here. Okay. Now first thing I said, the pericardial rub that will be absent. The second thing, for the accumulation of the fluid, we cannot feel the palpations on the apex bit regions. Okay. And whatever the other thing we'll get over here, whenever we get the accumulations of the fluid, try to understand, we'll see the shape of the heart, or you can say shape of the, if we just do the X-ray over here, if we do the X-ray on the X-ray findings, whatever the thing we'll see, normally if we just see on the X-ray, this is the aorta, this is the atrium, ventricle, these portions. In these cases, we will get in this way. But this is a normal set of the X-ray, right? But whenever we will see the development of the diffusion on the X-ray, whatever the changes we will see on the X-ray, we will see there will be extension of these layers. So in these cases, we will get what? Smooth. On the X-ray, we will get smooth, and see bilateral what? Equal enlargement, right? Enlargement of the heart. In these cases, we will get this type of the thing. Look on the X-ray. Now see, if we see the development of the accumulations of the fluid, if we see the accumulation of the fluid within the pericardial cavity, that the accumulations of the fluid, if you see gradually, so if you see the gradual accumulations of the fluid within the pericardium, for example, the pericardial cavity that can contain up to 2 liters of the fluid within the pericardium. If we see the gradual accumulations of the fluid within the pericardial sac, so the pericardial sac that can contain up to 2 liters of the fluid within the pericardial cavity. So these 2 liters of the accumulations of the 2 liter fluid, whenever it will be accumulated, there will be no hemodynamic changes, no significant hemodynamic changes. But if we see the accumulation of the fluids, if we see the accumulation of, for example, I am showing it over here, if you see the accumulation of the fluid over here, very first, so if you see the very first fluid accumulation, very first fluid accumulations, for example, whenever we will see the very first fluid accumulations, whenever it will just reach up to 250 ml of the fluid that will be accumulated very fast within the pericardial cavity, at that time this pericardium that will compress the heart from all sides, right? If I just show, for example, I am just considering this the heart, okay, I am considering this the heart, and try to understand from this figure that from the all side the pericardium that will compress the heart. Compression of the fluid over here, and whenever it will compress the, whatever the figure we will see over here, understand, we will get the compressed heart in this way. For example, so whenever the pericardium that will compress the heart for the accumulations of the fluid, okay, we will get this type of the figure of the heart. Okay, and this thing that is known as, whenever we see the very first fluid accumulations, for the accumulations of the fluid within the pericardial cavity, the pericardium that will compress the heart from all sides, this thing is known as cardiac tamponade or pericardial tamponade, whatever you can say. This thing that is known as cardiac tamponade. And as I mentioned in my previous video, whenever we see the development of the cardiac tamponade, at that time, see, whenever you are getting the development of the cardiac whenever you are just getting the development of the cardiac tamponade, at that time the heart, they will be not able to take more amount of the blood. So within the venous return that will be decreased. So whenever you are getting the development of the cardiac tamponade, definitely we will see the venous return that will be decreased. So whenever the venous return that will be decreased, definitely the cardiac output that will be also decreased. So whenever the cardiac output and the venous return is decreased, whatever the manifestations we will get for the, see, whenever the venous return that will be decreased, definitely the jugular venous pressures that will be increased, and whenever the cardiac output that is getting decreased, as a result, whatever the thing we'll see over here, whenever the cardiac output that will be decreased, you have to understand. So we'll get the systemic blood pressure that will be decreased also. The systemic blood pressure, whenever the heart is not able to pump the blood, definitely we'll see the within the systemic blood pressure. So the systemic blood pressure that will be also decreased. And along with that, for the this type of the structures of the heart, you will just hear the different kinds of the distant heart sound, that is known as muffled heart sound. So we'll get also what, the muffled heart sound. Muffled heart sound. Now let me repeat once again this part. Whenever we will see the development of the cardiac tamponade, for that we will see the venous return that will be decreased. As a result, the jugular venous pressures that will be increased. The second point I said that whenever the venous decrease, definitely the cardiac output that will be also decreased. So definitely the systemic blood pressure that will be also decreased. Along with that, I said we will get the distant heart sound. We will hear the distant heart sound in terms of, you can say, the muffled heart sound. So whenever we will get these three combinations over here, this thing is known as cardiac tamponade. Cardiac tamponade. Okay. Now, whenever we see the development of the cardiac tamponade, whatever the problem we will see. Okay. For that thing, let's draw the part over here. Is the heart. The heart is okay. Now, around that we will get what? The pericardium. for just before that I'll just draw the lungs, because there's something important about the lungs you are supposed to know. Okay. In the same way. Okay. So see, whenever we're getting the development of the pericardium, whenever we're getting the development of the pericardial effusions, at that time, as I said, the fluid that will be accumulated over here. And sometimes, as I said, the fluid up to 2 liters, the fluid that can be accumulated within the pericardium. So you can say the pericardium is having the capacity to accumulate 2 liter of up to 2 liter fluid. Sometimes we will see this pericardium with respect to the left side of the lung, left side of the lung, left side the lower border, you can say left side lower border. Now sometimes we will see this pericardial effusion that can extend it up to the this pericardial effusions that can extend it up to left lung, within the left lung by the lower border. So whenever we will see this portion, that means we can see over here in terms of, okay, so whenever it is extended up to left lung lower border, okay, whatever the thing we see over here, see, whenever we will see the compressions of these things in these regions. So as a result, within this part, for example, let me use a different color for it. In these regions, we will get the tendency of the collapsing. We will get the collapsing tendency within this part. So whenever we see, understand, I am repeating once again. Okay, this thing is this thing is very important. Whenever we will get the extension of the pericardial effusions from here to here, we will not have that problem with respect to the right side lung or right side lung, that will be managed. But what about the left side lung within the lower border? We will see whenever we get the extension of the pericardial effusions within the left lung within the lower border, at that time this extension of the pericardial effusion that will help, or you can say that will just do the collapsing of this lung parenchyma. Now whenever we are getting the collapsing of the lung parenchyma in these regions, so whatever the changes we will see right now, we are getting what? The collapsing tendency of these things. We get the collapsing of lung tissue or lung parenchyma, whatever it is. Now, whatever the changes we see, whenever we are getting the collapsing of the lung parenchyma, the lung tissue in the lower border of the left lung, whatever the thing we'll see, as we know in the voice, okay, as we know, whenever we are just talking from the vocal cord, from the larynx, the voice, that will reach from here to the what? Through the trachea, it will reach up to the bronchi, primary bronchi, secondary bronchi, and from here, as we know, we'll get the different kinds of the branches in terms of, the primary bronchi, secondary bronchi, tertiary. We get the different kinds of branches over here. Ultimately, we will see this sound. That will reach up to the within the alveolar. Whenever it will reach up to the alveolar, this type of the sound that is known as vesicular sound. This is the normal sound. Okay, what did I say? Let me repeat once again. Whenever we'll see the sound producing, these vocal cords, they are getting active at the time. The sounds that will reach from the larynx up to through the trachea, it will reach up to the primary bronchus, from the primary bronchus to the secondary, the tertiary terminals bronchus, and at last we'll get that will reach the sound that will reach up to how much? Up to the bronchit or alveoli. And whenever this sound that will reach up to the alveoli, this type of the sound that is known as, okay. So let me use the different point. I think that it will be better for you. Yes. This is known as vesicular sound. So under normal circumstances, we just hear the vesicular sound where within the right lung. But whatever the problem we'll see with respect to the left side lung, with respect to the left side lung, as whenever the voice that will come, whenever in the same way, in the voice, or you can say the sound that will reach from here to the bronchus, secondary through the trachea, primary bronchus, secondary bronchus, tertiary bronchus, ultimately within whenever the sound they will come over here, and this sound that will be not able to reach in the inner structures, rather this sound they will just hit this collapsing tissue. So we can see over here, whatever the thing we'll see, okay, whenever it will just do the collapsing over here, try to understand, whenever we'll see this sound, they will come over here and they will hit on this collapsing portion, collapsed lung tissues over here. At that time we will see the productions of the different kinds of the sound that is known as bronchial sound. Bronchial sound, okay. Now when you will see when you will hear the bronchial sound, when you are getting for the development of the pericardial effusions, we are getting the collapsing tissue where within the lung. So whenever the sounds that will reach from the larynx to the through the trachea to the bronchus, ultimately where within the alveoli, at the time this sound that will be not able to reach from here to this ultimate structures, or rather it will, whenever it will hit, at that time we will see productions of the another kind of the sound that is known as bronchial sound. And this bronchial sound that can be best heard in terms of the on the back side if we use the stethoscope, okay, within the back side, where within the lower, where we can see in the lower scapular angula, okay, the lower angle of scapula, you can hear this sound over there, okay. Okay, so whatever the thing just learned up to this much, this whole thing that is known as Ewart sign. Ewart sign. If I say what is Ewart sign, see, for the development of the pericardial effusions, we are getting the development of the collapsing tendency within the lungs. When you are getting the collapsed lung tissue over here, whenever the sound is coming from the larynx to the trachea to the bronchial systems, ultimately within this collapsed tissue over here, they will get the productions of the different kinds of the sound that is known as the bronchial sound, okay. So this whatever the things we are getting over here, that is known as Ewart sign, is known as Ewart's sign, okay. Now we'll talk about how can we just do the other investigations and the treatment. So for the other investigations we can do in terms of in these cases, as far as the other investigation is concerned, in these cases we can do the echo. On the echo, we can just exactly we can come to know that whatever the fluid and how much fluid is getting accumulated in these regions, and whatever the structural deformities, we can find out from here easily. After the echo, we can do the CT scan or the MRI. We can do the CT scan or the MRI for just to watch the proper, just to investigate. We can say over here of the different parts of the hearts and the lungs as well in these cases, okay. And along with that, we can also do the, as I mentioned earlier, we can do the chest X-ray. We can do the chest X-ray over here, okay. And apart from these things, we can also do in terms of the different kinds of the tests. Whatever the test we can do, let's write it in the other place over here. For example, apart from that, we can just do, as is the inflammations, we can do the test for ESR. In this case, the erythrocyte sedimentation rate that will be increased, along with the C-reactive protein that will be increased, along with the total leukocyte count that will be also increased. Why we need to do this type of the test? These are the very simple tests you can think, but whenever we will come up in terms of the treatment at the time, after giving the drugs, we have to check out whether these values are getting decreased or not, or these values are coming down to back to normal form or not, okay. So that's why. Okay. So that's why you have to make sure that we have to do these tests. Now, as far as the treatment is concerned, whatever thing we can do over here. So let's talk about the treatment. We can write down the treatment over here, guys. Okay. So as far as the treatment is concerned, whatever the thing we can do over here. So for the first line of the drugs, as far as the treatment is concerned over here, okay, the first line of the drugs, we have to use what? We can use the aspirin, or we can use like other kinds of non-steroidal anti-inflammatory drugs. So the first line of the treatment, we have to use the aspirin or non-steroidal anti-inflammatory drugs. But we have to make sure one thing: if we just get the individual, if we can come to know the individual is having the myocardial infarctions, after that he is developing the pericarditis over here. At that cases, we are not supposed to use the non-steroidal anti-inflammatory drugs. In ascites, we are not supposed to use in these cases. If we come to know the individual is suffering from the myocardial infarctions, after that if we see the development of the acute pericarditis, at that time we are not supposed to use the non-steroidal anti-inflammatory drugs. Okay, we have to rule out this thing. And after that, if we see that after giving these all things, the condition is not coming to the better conditions, at that time we have to use the colchicine. So what is the drug colchicine? Okay, so at first we have to use the aspirins or the non-steroidal anti-inflammatory drugs. Whenever we are just coming to know that after using these things we are not getting the better result, at that time we can use the colchicine. Now colchicine basically what it will do, for example, if it is supposed to be the neutrophil, so within the neutrophil we will see there is a presence of one type of the protein that is known as tubulin. So for example, this is the tubulin. Now what it will do, it will help the neutrophil to take it forward. Okay, so it will help the neutrophil to make it movable forward directions. But whenever the neutrophil that will come in these directions, along with that another function for this tubulin, what it will do, it will just, what it will do, the tubulin from this structure, you will get the polymerizations of the tubulin protein over here. Another thing we will get, this will be removed from here, and these things that will be added in these portions. As a result, we will see the neutrophil that will be easily reachable within the inflammatory regions. But if we use the colchicine, what is the function of the colchicine? Try to understand the colchicine that will get bind along with what? The colchicine that will get bound. Bound along with the tubulin protein, and it will not let the tubulin to further polymerization. It will just inhibit in the polymerizations of the tubulin protein. So the colchicine that will inhibit the polymerizations of the tubulin protein within the neutrophil. So whenever we will get these polymerizations, of the tubulin that is getting inhibited, as a result the neutrophil, they will be not able to come within the inflammatory regions. So whenever the neutrophils are not able to come within the inflammatory regions, definitely we can say that the inflammatory, whatever the inflammations we are getting over here, that will be reduced. In a nutshell, we can say the whole inflammatory process that will be reduced. So ultimately we can say, as far as the symptomatic, okay, you can see the symptomatic relief we can do over here. So in terms of the treatment, we have to make sure that we are just making sure that the symptomatics, and we have to also to do the treatment using the underlying cause. So underlying cause, it's not most of the cases the idiopathic, so we have to focus in terms of the systematic or relief over here. So whenever we will see the symptomatics, all these things are coming in these cases. So if you can just remove these things, the patient's condition that will come back to better conditions. Okay. Now this was all about in terms of the investigations and the treatment. And another thing I have already explained you that in terms of different kinds of the biomarkers, in terms of the CKMB, troponin T, all these things we can just do as far as the if we just do the development of the pericarditis induced the myocarditis or the myocardial infarctions over here, we can just do the test over here. So that's all for the investigations and the treatment. The next part of the videos will continue in the myocarditis. Okay. So if you have any questions, you can ask me through the comment sections. I will be there to help you guys. Thanks for watching. See you in the next video soon.